Welcome. Today my topic of discussion is chronic kidney disease. It is an important topic of general medicine for two reasons. Number one, it is the common end result of very two common non-communicable diseases. It is hypertension and diabetes mellitus. Number two, chronic kidney disease patient remain unaware about his or her disease until the disease is too much advanced. So it is a silent killer. For this reason, medical professionals must be aware about this disease, particularly its prevalence, its pathology, its clinical features and management. Okay, let us start. Before discussion the actual topic, I shall discuss three case summaries related to the chronic kidney disease. Case study 1. 81 years male came to the OPD having history of hypertension for the last 20 years but on irregular medication. Started amlodipine 10 mg once daily, but the patient reported after 1 month with history of leg swelling and shortness of breath on exertion. Initially, it was thought that amlodipine was the cause of leg swelling, but further investigations, including echocardiogram, chest X-ray, creatinine, and previous creatinine report, which was initially hidden by the patient, so it was a case of chronic kidney disease with fluid retention and responded to furosemide infusion. So the conclusion is hypertensive patient on calcium channel blocker may present with leg swelling, but chronic kidney disease with fluid retention should always be kept in mind. Case study 2. A 52 years old female with poorly controlled type 2 diabetes came to OPD with extreme tiredness and fatigue for the last 6 months. CBC revealed hemoglobin 9.2 gram per deciliter with normocytic normochromic RBC pattern, TSH within normal range. However, eGFR was 29 milliliter per minute per 1.73 meter square body surface area. Ultrasonography showed bilateral reduced kidney size with loss of corticomedullary differentiation, suggestive of diabetic nephropathy with chronic kidney disease and normocytic normochromic anemia as a complication. So the conclusion is tiredness and fatigue may be due to hypothyroidism or anemia, but CKD should be kept in mind. Case study 3. A 75 years old male with enlarged prostate came to the general physician for fever with urinary obstruction. Investigations revealed UTI with fasting blood glucose 189 mg per deciliter and serum creatinine 2.28 mg per deciliter, corresponding eGFR 21 milliliter per minute per 1.73 meter square. He was advised for antibiotics with glimepiride 0.5 mg per day. After 5 days, the patient was admitted with hypoglycemia and was treated. The conclusion is a patient with stage 4 CKD, that is eGFR less than 30, should not be treated with sulfonylurea group of drug. Now come to the actual topic. 1 in 2 people with reduced kidney function, not in dialysis, do not know that they have it. This is the slide of prevalence of chronic kidney disease. Global prevalence, 8 to 16% people across the globe suffering from chronic kidney disease. From this slide we see here that largest bird over the Nigeria and the smallest bird, I think here it is the New Zealand. And come to the India, here it is around 17%. 17% of the Indian population on average are suffering from chronic kidney disease. In this slide we see hypertension and its end results on the left side and diabetes mellitus and its end result on the right side. In both sides, chronic kidney disease is common. Thus, from this discussion, we can easily guess the importance of chronic kidney disease, which is the end result of two common diseases like hypertension and diabetes mellitus. Now come to the estimation of glomerular filtration rate. There are three equations in this slide. Cockcroft-Gault equation, MDR-D equation, and CKD-EPI equation. CKD-EPI means chronic kidney disease epidemiology collaboration equation. For the first one, we need age of the patient, body weight of the patient, and serum creatinine. For the second one, it is serum creatinine and age. And for the third one, it is the serum creatinine and age of the patient. Out of three, I think it is the CKD-EPI equation is better for assessment of the glomerular filtration rate. Now come to the anatomy and physiology of the glomerular structure. In this slide we see the glomerular anatomy and physiology where afferent arteriole is going to form glomerular capillary and capillaries are ending into the efferent arteriole. Blood is coming through the afferent arteriole and entering to the glomerular capillaries where outward directional hydrostatic pressure is 55 mm mercury, whereas pressure towards the glomerular capillary, that is inward directional pressure, is the summation effect of inward directional colloidal osmotic pressure, that is 25 mm mercury, and inward directional Bauman's capsular pressure, that is 15 mm mercury. And the total inward directional pressure is 20 plus 15 equal to 40 mm mercury. Thus, the net pressure effect is outward directional pressure minus inward directional pressure, that is 55 minus 40 equal to 15 mm mercury is going towards outward direction, which is the driving force for glomerular filtration, and by this filtration the average glomerular filtration rate is maintained as 120 milliliter per minute per 1.73 meter square body surface area. Why 1.73 meter square? Because this is the average human body surface area. Now come to the definition. CKD is defined as chronic kidney damage when glomerular filtration rate is less than 60 milliliter per minute per 1.73 meter square for 3 months or more, irrespective of cause. Albumin creatinine ratio more than 30 mg per gram of creatinine in 2 of 3 spots urine specimen for 3 or more months also supplements the GFR definition. Urine albumin creatinine ratio also determines the early kidney damage, risk of progression in any stage of the CKD, and response to therapy. Albuminuria and chronic kidney disease. Urine ACR 17 or more in male, 25 or more in female, but less than 30 mg per gram of creatinine. It is mildly increased ACR for early detection of the kidney disease. UACR 30 to 300 mg per gram creatinine. It is moderately increased ACR. Previously it was known as microalbuminuria. UACR more than 300 mg per gram of creatinine, severely increased ACR. Previously it was known as macroalbuminuria. It is an irreversible state. Albuminuria determines generalized endothelial dysfunction and a marker for cardiovascular morbidity like stroke and myocardial infarction. This is the slide of kidney disease improving global outcome, KDIGO classification of chronic kidney disease. On the left side, we see the glomerular filtration rate, which helps in the stage determination of chronic kidney disease. Depending upon the glomerular filtration rate, we have divided chronic kidney disease in 5 stages, and stage 3 is again subdivided into stage 3A and stage 3B. When the glomerular filtration rate 90 or more, it is normal or high, it is stage 1. If it is 89 to 60, that is mild reduction, stage 2. 59 to 45, mild to moderate reduction, stage 3A. 44 to 30, moderate to severe reduction, stage 3B. 30 to 15, severe reduction, stage 4. less than 15, also known as kidney failure or end-stage renal disease, yes at stage 5. Now come to the right side, protein in reading, albumin creatinine ratio. It helps in risk of progression determination of any CKD patient in any stage. Depending upon the albumin creatinine ratio, it is divided into three columns. When it is less than 30 is the first column, 30 to 300 the middle column, more than 300 is the third column. Now, let us see, say for example, any patient of stage 2, that is in the second row. If he or she comes with urine ACR report less than 30, he or she will be placed in the low risk zone, that is first column, second row. If another patient comes with urine ACR report more than 300 of safe stage 2, he or she will be placed in the high risk zone. Similarly, if we think for a patient of stage 3B comes with UACR report less than 30, he or she will be placed in the high risk zone, whereas another patient comes with the UACR report more than 300, he or she will be placed in the very high risk zone, that is the fourth row, third column, red shade here. So, from this discussion, we can easily conclude that both glomerular filtration rate and urine ACR report are important for assessment of CKD patient. Next, come to the etiologies of chronic kidney disease. First is the diabetic nephropathy. Glomerular hypertension due to afferent arterial dilatation and RAS-mediated efferent arterial constriction causing protein leakage, mesangial expansion and glomerulosclerosis. Next come the hypertensive nephropathy. Hypertensive arteriolosclerosis in the glomerular afferent arteriole causing ischemic changes in the glomerular and postglomerular structure causing glomerulosclerosis. Next is the glomerulonephritis, autosomal dominant polycystic kidney disease or other cystic kidney, tubulointerstitial nephropathy, chronic obstruction of the urinary outflow tract as in prostatomegaly, neoplasm in the kidney outflow tract, recurrent pyelonephritis, vesico-ureteric reflux. Out of all these causes, diabetic nephropathy and hypertensive nephropathy are the most common causes of CKD. Here we see in the left side is the normal glomerulus and the right side we can see here the sclerosis. The effect of hyperfiltrating glomerulus, these are sclerotic changes occur in the glomerular structure. Now come to the pathophysiology and biochemistry of uremia. Serum urea and creatinine concentration are used to measure the excretory capacity of the kidney. Large number of toxin, fluid and electrolytes accumulate in addition to urea and creatinine. When glomerular filtration rate declines, that characterizes the uremic syndrome or azotemia. Chronic kidney disease is associated with systemic inflammation with elevation of C-reactive protein and acute phase reactant. Now come to the complication, clinical features and management. First of all is sodium and water retention. Sodium retention and attendant extracellular fluid volume expansion occurs. What happens? Peripheral edema and hypertension. How to manage? Dietary salt and water restriction, daily fluid intake 1000 to 1500 milliliter for stage 3 to stage 5. Avoid positive fluid balance. How to check? Look for intake and output balance, daily body weight measurement, lung basal Grachel's auscultation. Loop diuretics like furosemide, torsemide, etc. even in infusion pump. Metolazone may be added. Dialysis in refractory cases. In this slide, we see here a patient with chronic kidney disease with fluid retention presenting with puffy face and periorbital edema. In this slide, you see another patient with bilateral pedal edema. Next complication, potassium retention. Potassium retention causing hyperkalemia, clinically as many palpitation and muscle weakness. This is the ECG changes in hyperkalemia. Hyperkalemia means I want to say when the serum potassium is more than 5.2 milliequivalent per liter. The first change is tall and peak P wave in ECG. Next is the flat P with wide PR interval, wide QRS, elevation of J wave, sine wave pattern. This is an emergency situation. Next, come to the hyperkalemia management. Hyperkalemia means serum potassium more than 5.2 milliequivalent per liter. When potassium is more than 5.2 but less than 6 without any ECG change, long-term management is enough. Next, potassium more than 5.2 but less than 6 with ECG changes. It needs emergency management followed by long-term management. And then potassium more than 6, emergency management followed by long-term management. Hyperkalemia management continue. First is the emergency management. Three types of management are mentioned here in addition to the hemodialysis. The first one is the calcium gluconate 10 milliliter IV over 10 minutes. Next is the regular insulin 10 units in 50 milliliter of 50% dextrose solution. The third one is the 20 milligram albuterol in solution for nebulization and hemodialysis in refractory cases. Now come to the long-term management. Low potassium diet, caliuretic diuretics, potassium binding resin, calcium polystyrene sulfonate, and dose reduction of potassium retaining medication, that is AC inhibitor or angiotensin receptor blocker. Metabolic acidosis. In chronic kidney disease, pH rarely falls below 7.32. However, respond to alkali supplementation, it is sodium bicarbonate. This is the slide showing the CKD and bone changes. Here we see a disease kidney of chronic kidney disease. As we know that kidney is the source of 1-hydroxylation of vitamin D, there will be less amount of 1-hydroxylation in CKD. Thus, less 125 dihydroxycholecalciferol, that is calcitriol, will be formed. Less calcitriol will cause less calcium absorption from the intestine, which results in hypocalcemia. On the other hand, in CKD, there will be phosphate retention by the kidney, which binds serum calcium to cause hypocalcemia. So, hypocalcemia from both sides stimulates parathyroid gland to cause excess parathormone secretion. An effect of excess parathormone hormone in bone result in osteitis fibrosa cystica, that is bone cyst, bone fibrosis and bone hemorrhage. On the other side, decreased calcitriol causes osteomyelitic bone changes. Thus, our aim of treatment is number 1, decrease serum phosphate level by using phosphate binder like cevilamine, calcium acetate and calcium carbonate. And number 2, external supplementation of calcitriol. Calcium phosphate homeostasis and bone. Declining glomerular filtration rate, as a result, phosphate retention, parathormone secretion, bone resorption, as a result, formation of bone cyst, bone and myofibrosis and brown tumor, that is osteitis fibrosa cystica. Clinical manifestation, bone pain, swelling, fracture. Treatment: phosphate binding agents as cevilamide, calcium acetate and calcium carbonate. Here we see in the X-ray on the upper part of the tibia there is bone cyst, renal osteodystrophy changes. In another X-ray there are bone cyst in the tibia, manifestation of the renal osteodystrophy. In this slide we are see the X-ray showing the lizard zone of osteomalacia, the upper medial aspect of the femur, cortical region, arrow showing the lizard zone. In another X-ray, arrow showing the lizard zone in the iliopubic junction bilaterally. So osteomalacia, lizard zone are showing in these two X-rays. Now come to the cardiovascular abnormalities. Hypertension managed by salt restriction, diuretics, AC inhibitor, angiotensin receptor blocker, calcium channel blocker. Target blood pressure is less than 130 by 80 mm mercury. Concentric left ventricular hypertrophy, the cause of diastolic dysfunction. Left ventricular failure, cause of systolic or diastolic dysfunction. Coronary artery disease, pericarditis. Now the most important statement, most patients with CKD succumb to cardiovascular disease before even reaching to stage 5 of CKD. Now come to the pulmonary abnormality. Increased permeability of the alveolar capillary membrane occurs in uremia, leads to low pressure pulmonary edema in advanced chronic kidney disease. This is the slide which shows the afferent arteriole, glomerulus and efferent arteriole. In this slide, I want to show the mechanism of action of the AC inhibitor or angiotensin receptor blocker over the efferent arteriole. What happens? If we administer AC inhibitor or ARB, it dilates the efferent arteriole. As a result, there will be fall of intraglomerular pressure. We know that AC inhibitor or ARB causing dilatation of the systemic artery, causing lowering of the blood pressure. In addition to that, AC inhibitor or ARB have additional renoprotective action by dilating efferent arterioles of the glomerulus. As a result, there will be fall of interglomerular pressure and decreased chance of glomerulosclerosis. Thus, very useful to halt the disease progression of both hypertensive and diabetic nephropathy. Now come to the hematological abnormalities. Anemia, so normocytic normochromic type. Anemia in CKD is usually due to number 1, deficiency of the erythropoietin from diseased kidney. Number 2, diminished RBC survival in uremic environment. Number 3, bone fibrosis. Number 4, anemia of chronic inflammation. Number 5, iron, folic acid and vitamin B12 deficiency. Clinical manifestation, weakness, fatigue. Treatment, erythropoietin, iron, folic acid, vitamin B12. Hemoglobin target is 10 to 11 gram per deciliter. Abnormal hemostasis. Uremic environment causing abnormal platelet adhesion and aggregation, causing increased bleeding time. As a result, there will be easy bruising, menorrhagia and GI bleeding. Treatment, desmopressin and transfusion. Now come to the neuromuscular abnormalities. Disturbance in sleep and memory. Hiccup, cramp, twitching. Cramp and twitching is very important. Flapping tremor, asterixis. Peripheral neuropathy, initially sensory, more in the distal lower limb, known as restless legs syndrome. Encephalopathy. Now come to the gastrointestinal and nutritional side. Uremic fever due to salivary breakdown of urea to ammonia. Unpleasant metallic taste, dysgeusia, anorexia, nausea, vomiting related to the uremic toxins. acid peptic disorder, protein energy malnutrition, dermatological abnormalities, pruritus, an irritating feature of chronic kidney disease patient treated by local moisturizers, topical glucocorticoids, and oral antihistamines. Pigmentation due to deposition of pigmented urochromes, udemic frost in the skin, calciphylaxis, a devastating condition of calcium deposition in vascular bed and soft tissue. The slide showing the uremic frost. It is the eccrine deposition of urea crystal on the skin surface of patient with severe uremia. Here we see the uremic frost over the forehead of this patient. This is another image of uremic frost over the knee region. See here the early calciphylaxis, the advanced calciphylaxis. Now come to the endocrine and metabolic abnormalities. Increased plasma insulin level occurs due to impaired insulin removal by the diseased kidney. Patient with insulin therapy needs close glucose monitoring. Low estrogen level, menstrual abnormalities occur, infertility, inability to carry pregnancy to term, low testosterone level as a result sexual dysfunction with oligospermia, high parathyroid hormone level. Next come to the investigation side. Serum urea creatinine EGFR persistent abnormality for 3 months is significant. UACR, that is urinary albumin creatinine ratio, 2 positive in 3 tests over 3 months is significant. Urine REME, serum sodium, potassium, calcium, phosphate, bicarbonate, vitamin D and parathormone, fasting blood glucose, PP blood glucose, HbA1c, hemoglobin percent, iron, vitamin B12, folate and breathing time, ECG and echocardiography, chest x-ray, bone x-ray, renal ultrasonography to see the kidney size, particularly if the longitudinal section kidney is less than 8 cm, it is suggestive of CKD, to see the renal cortical echo texture, to rule out polycystic kidney disease, to rule out outflow tract obstruction. Next is the kidney biopsy. It is of limited value in stage 4 and stage 5. Now come to the management of the health problem in your community. First, to rule out the acute renal failure from CKD. How can I rule out? By history and imaging assessment. If the patient complaining of high level of creatinine for long duration, more than 3 months, it is suggestive of CKD. And imaging assessment also help us. If we see by ultrasonography the kidney sizes are small, it is less than normal size kidney with loss of corticomedullary differentiation, we can say this is a case of chronic kidney disease rather than acute renal failure. Now come to the prevention of incidence of chronic kidney disease. How can we prevent the CKD onset? First of all hypertensive and diabetic patients should be screened for EGFR and urinary albumin creatinine ratio at the first OPD visit and annually. And then proper control of hypertension, if any. Proper control of diabetes, if any. And last not the least, control intraglomerular pressure by ACE inhibitor or angiotensin receptor blocker unless it is contraindicated. Now the slowing of the CKD progression. Once CKD is established, our aim should be to slow the disease process. Strict control of blood pressure once again, and our target is blood pressure is 130 by 80 mm mercury, particularly in the proteinuric patient. Control of diabetes if any. Control of intraglomerular pressure by ACE inhibitor or angiotensin receptor blocker unless contraindicated. Dietary protein restriction 0.6 to 0.8 gram per kg body weight with 50% high biological value to prevent protein-induced further glomerular injury. Treatment of complication. It is complication-wise treatment may need renal replacement therapy in few cases. Now come to the management continuum. Renal replacement therapy, that is hemodialysis or peritoneal dialysis or renal transplant. In encephalopathy indication, second indication uremic pericarditis, anorexia and nausea in irreversible state, malnutrition, electrolyte abnormality, particularly hyperkalemia, extracellular fluid volume overload, refractory to other measures, end-stage renal disease. Come to the question. The least first is the NSAID and COX-2 inhibitor. Next is the combined use of AC inhibitor and angiotensin receptor blocker. Do not use AC inhibitor and angiotensin receptor blocker simultaneously because they can cause acute kidney injury and adverse cardiac events. Next is the antibiotic drug, which depends upon renal clearance. Particularly, I want to mention biguanides, that is metformin and sulfonylurea group of drug. When GFR is less than 50, be careful. I think it is better to avoid these two drugs when eGFR is less than 50 and never when it is less than 30. Next is the radiographic contrast and gadolinium contrast for MRI scan, antimicrobial, which depends upon the renal clearance, lithium containing drugs, because when the renal clearance is slow, it is better to avoid or better to reduce the lithium containing drugs for the safety of the patient. This doctor is thinking about his CKD patient. His idea is use AC inhibitor or ARB for both hypertensive and diabetic patient for kidney protection. He is also thinking about the phosphate binder and calcitriol from CKD stage 3 for bone protection. The most important slide, take home message. Diagnosis of chronic kidney disease depends upon estimation of eGFR. CKD is defined when eGFR is less than 60 ml per minute per 1.70 meter square for 3 months or more. 10 to 20% of the population are suffering from chronic kidney disease. CKD patients remain unaware about his or her disease unless it is advanced. Thus, a high degree of clinical suspicion must be present for early diagnosis of chronic kidney disease. This is a very important statement. Hypertension and diabetes mellitus are two most common causes of CKD. Thus, control of these diseases in early stage can prevent CKD onset. AC inhibitor or ARB is useful to prevent CKD development in hypertensive and diabetic patients by decreasing intraglomerular pressure. Phosphate binder and calcitriol are also useful to prevent the onset of bone disease if started when eGFR falls below 60. This is the slide telling us be aware of the silent killer. So after awareness, we got happy kidney. Thank you.